We've been doing this since about I think May or June, and we've had really a variety of presenters, and it's been wonderful. And today we're going to focus more on survivorship and supportive care, a really important part of breast cancer care. So we have two presenters. Our first presenter is Dr. Tara Rick. She is a research associate in cancer survivorship here at the University of Minnesota and a physician associate in hematology and oncology here at M Health Fairview. And she does quite a bit of research on improving quality of life, sexual health, menopausal care amongst breast cancer survivors, especially around endocrine therapy. She has earned a PhD in radiotherapy from Erasmus University in the Netherlands, and she studied radiotherapy access and cancer care across sub-Saharan Africa. She also serves on the board of the Foundation for Cancer Care in Tanzania, where she does a lot of work and remains engaged in global oncology research. She mainly looks at barriers to treatment and workforce development. Our second presenter is Dr. Linda Koehler, who is an associate professor here at the University of Minnesota in the Department of Family Medicine and Community Health, Division of Physical Therapy and Rehab Science. She is a licensed physical therapist and a certified lymphedema therapist with the Lymphology Association of North America. She has been working with breast cancer survivors for over 25 years. And she does, the mainstay of her research is focused on lymphedema, axillary Webb syndrome, and cancer survivorship. So we are so happy to have you both, and I'll hand it over to Dr. Rick.
Great. Thanks, Jenny. All right, let me just get my slides up here. All right, can you see my slides?
Yep, looks great.
Perfect. All right, so good morning or good afternoon, depending on where you're joining us from today. I'm glad you're here. So we're going to talk about survivorship care in breast cancer and how we can deliver it across different resource settings. So as oncology providers, of course, our first goal is to cure our patients, but we also share another goal, to reduce suffering. We usually think about that in the context of late stage disease when cure isn't possible and we're focusing on palliation of symptoms. But survivorship is about helping people live better with or beyond cancer. Survivorship care then really overlaps with palliative care as they are both providing supportive care. And as breast cancer survival improves globally, supportive care becomes essential. So today I'm going to focus on what is feasible, high value, and scalable, no matter where you practice. We can't cover everything about cancer survivorship in a short session, so I'm just sticking to the low-hanging fruit, the things we can do that can really make a difference in our patients' day-to-day lives. So here's what I'm hoping to get through today. First, we'll define the key elements of cancer survivorship care, and we'll look at these pieces and how they can be adapted depending on where you practice, whether it's a limited, core, or enhanced resource setting. Second, we'll walk through the high-impact supportive care needs that we see most often, and I'll share some practical evidence-based strategies that can be scaled to different settings. And then finally, we'll look at how to actually weave survivorship into routine oncology care. So that's our roadmap. So before we dive into the details, I just want to ground us in why survivorship care matters. Let's start with the definition of what is a cancer survivor. We consider a cancer survivor as somebody as a cancer survivor from the moment of diagnosis through the rest of their life. So when you look at global numbers, breast cancer survivorship is growing quickly. There are now more than 8 million breast cancer survivors worldwide. And from the graphic, you can see that most survivors live in Asia, Europe, and North America, but the numbers are also rising in Latin America and Africa. This means more people are living longer with and beyond breast cancer, and there's more need for ongoing support. So despite this growing need, survivorship services are still really fragmented or not formally developed. And this is across the world. This is not depending on resource site. because cure really is a priority of a lot of cancer programs. So again, our goal today is to focus on practical high impact approaches. Okay, so what is survivorship care? We defined the what is a cancer survivor. So from the time of diagnosis through the balance of life. But what does it include exactly? So it includes things like surveillance for recurrence and for new primary cancers, which is often what we traditionally think about. But a huge part of survivorship is also managing side effects and mitigating late effects. Things like pain, fatigue, cardiac issues, neuropathy, menopausal symptoms. These are the things that patients live with day to day and have a big impact on their quality of life. So health promotion also plays a huge role. Simple interventions supporting smoking cessation, encouraging physical activity, and basic nutrition guidance can really make a meaningful difference. And then we can't forget things like psychosocial needs, mental health, sexual health. These are main contributors to well-being and are often the areas that patients feel the least supported. And then finally, survivorship relies on good care coordination when possible. So between oncology, primary care, if accessible, and community or supportive resources that can be leveraged. So different resource settings will address these domains to different degrees, of course, but the framework is still the same no matter where you practice. So a helpful way to think about survivorship care, especially in global settings, is through a tiered approach. So the basic core and enhanced levels, which I'll build on top of each other. So the basic level is what can be done anywhere. It's recognizing symptoms early, reassuring patients, screening for things like fatigue and pain, and giving simple practical advice on exercise and lifestyle. These low cost interventions have a big impact. One of the most influential studies in this area was the Holmes JAMA paper from 2005. They followed almost 3,000 women with early stage breast cancer and found that women who did the equivalent of about 3 to 5 hours a week of brisk walking had 50% lower risk of dying from their breast cancer. So even very basic counseling on physical activity can make a meaningful difference in survival. The core level adds a bit more structure. This might include routine follow-up, basic screening where available, managing menopausal symptoms, and addressing bone and cardiac health when you can. And at the enhanced level is where multidisciplinary survivorship teams come in, where you have rehabilitation services, sexual health services, psychology, cardio-oncology, things that require more infrastructure and more specialized staff. But the important message is that at every setting, you can deliver cancer survivorship care. The tier simply reflects the resources that are available. And the goal is the same, to focus on the highest value interventions that make the biggest difference on patients. And I want to comment on the level of evidence for kind of what I'm talking about during this presentation. The NCCN survivorship guidelines as a whole are a category 2A, meaning it's uniform expert consensus rather than and with mixed evidence. For some areas like exercise, bone health, and non-hormonal vasomotor symptoms, we have strong randomized controlled trials and meta-analyses. And then for other aspects of survivorship care, like sexual health, distress management, and models of care, we're working more from smaller trials plus expert consensus. So what I've done in this talk is I've combined the guidance framework with the best available evidence and then stratified it by basic, core, and enhanced resource settings. All right, so let's get into kind of the meat of the talk. So let's talk about endocrine therapy. A majority of our patients are estrogen receptor positive, and endocrine therapy is effective. It reduces recurrences by about 30 to 50%. But the challenge is really adherence. 40 to 60% of patients stop or take their endocrine therapy inconsistently. And it's really the symptoms that drive this. Hot flashes, joint pains, vaginal dryness, fatigue, brain fog, insomnia, mood changes. These are not small issues. And they can have a huge impact on patients' quality of life and their ability to limit function from day to day. And this then also influences how a family is functioning. So acknowledging these symptoms and managing them is essential if we want patients to stay on therapy. So hot flashes and night sweats, so the vasomotor symptoms, are some of the most visible reasons that patients struggle to stay on endocrine therapy. And this is because we can physically see hot flashes in our patients, but also this is what's really been the most studied. And some patients have minimal symptoms and really struggle, and some really struggle. So at the basic level, what we can do to make an impact, we can imply simple strategies like encouraging regular exercise, helping patients identify and avoid triggers, recommend dressing in layers, and reinforcing sleep hygiene. Basic things, really just normalizing the topic and the patient feels seen. These are things that people can do right away. And then at the core level, we can add medications that have solid evidence behind them. So medications like gabapentin, venlafaxine, certain SSRIs, clonidine, and oxybutynin. These are generally affordable, fairly widely available in many settings, and don't interact with endocrine therapy when chosen appropriately. So here I've highlighted in green the drugs that can be appropriately taken with tamoxifen. And then with the enhanced level, patients can have access to more specialized options like cognitive behavioral therapy for insomnia, acupuncture, access to menopause clinics, and emerging agents like fezolinetant or elinzanetant that are effective, but often require more resources, costs, or monitoring. And then sexual health. I want to take a moment to plug sexual health here because it is often overlooked, and yet it's central to survivorship. The WHO reminds us that sexual health is fundamental to the overall health and well-being of individuals, couples, families, and to the social and economic development of communities and countries. A big statement. And for many breast cancer survivors, sexual concerns are extremely common. Vaginal dryness, pain with intercourse, loss of desire. These issues affect relationships, mental health, and quality of life. And if we don't ask about it, patients don't tell us about it. At the basic level, we can normalize this conversation, show that it's a valid health concern, involve partners when appropriate in the conversation, and recommend simple low-cost tools like just talking about using lubricants and vaginal moisturizers. At the core level, we can expand these options and tailor them to symptoms. And this includes having access to a wider variety of lubricants. There are water-based, silicone-based, oil-based lubricants. We can also talk about using regular vaginal moisturizers 2 to 3 times a week, not just at the time of sexual activity, but for improving the moisture. And then options range from water-based products to hyaluronic-based products. And if these non-hormonal options fail, we can also talk to our patients about topical estradiol, which is safe and effective even in patients with estrogen receptor positive breast cancer. And at the enhanced level, patients may benefit from referral to sexual health specialists, sex therapist, or pelvic floor physical therapy, where trained professionals can address pain and function issues safely. All right, now some of the other endocrine therapy or general symptoms include fatigue, pain, and emotional distress. And for fatigue, the most effective approach, once you've ruled out anemia or other causes, is actually very simple. The data really shows that regular walking, good hydration, and consistent sleep routines can be effective. For pain, especially joint pain from endocrine therapy, NSAIDs can help. Along with stretching, gentle physical activity, heat in some aspects can be helpful. But the key is to avoid prolonged inactivity, which often makes the symptoms worse. Patients will tell us that they feel the worst in the morning when they're getting out of bed. And for distress, one of the most powerful things we can do is to normalize what patients are feeling, letting them know that these emotional reactions are common. When possible, we can connect them with peer or community support groups that can make a tremendous difference. And at the enhanced level, survivors can benefit from access to psychologists, counselors, group therapy, other mental health support that can address anxiety, depression, trauma, and coping challenges more deeply. Next, bone and cardiac health are two areas of survivorship that don't always get enough attention, but they're really important, especially for patients on aromatase inhibitors or those who have received anthracyclines. So at the basic level, there are simple things we can do. We can encourage weight-bearing exercise. We can make sure patients are getting enough calcium and vitamin D in their diet. And if not, we could talk about supplementation if possible. And we can routinely check blood pressure. These low-cost measures can help maintain bone health and reduce cardiovascular risk. And then at the core level, we can start adding screening when resources allow. This could include getting a DEXA scan for women on aromatase inhibitors to assess their fracture risk, and then considering an echocardiogram for patients who have received significant anthracycline exposure or who have other risk factors, or especially for patients who are having symptoms, shortness of breath, lower extremity edema, et cetera. And then at the enhanced level, we can offer more specialized care like bisphosphonates, denosumab for fracture prevention, and then referrals to cardio-oncology for patients at higher risk of cardiovascular issues. And then I also want to comment on secondary malignancies in breast cancer survivors. I don't know if we always think about this very much, but breast cancer survivors also face an increased risk of developing secondary malignancies over the course of their lives. The most common are contralateral breast cancers, cervical cancers, lung cancers, colorectal. So basically all solid tumors patients are at risk for. And then in some cases, treatment-related hematologic malignancies, like if a patient has had an anthracycline. So that risk varies based on a lot of things: age, genetic background, lifestyle, treatment exposures. And then at the basic level, the goal is awareness and early detection. So encouraging breast self-awareness, ask patients about new and concerning symptoms, and then follow whatever national screening programs are available, like cervical cancer screening when feasible. And at the core level, you could start adding more structured surveillance, like annual mammograms for the conserved breast or breasts, routine clinical breast exams, and ensuring patients keep up with cervical cancer screening. And then at the enhanced level, patients can benefit from genetic counseling or testing, particularly if they were diagnosed young or have a strong family history. Okay, so now practically, how do we embed survivorship into daily care? A practical way to integrate it is to use simple visit checklists during chemotherapy, surgery follow-up, and radiation visits. I know we have multidisciplinary group here today. These checklists help us catch symptoms early, reinforce key health messages, and ensure nothing falls through the cracks. And they can also just improve our efficiency with these things. And then task shifting is also incredibly effective. Nurses, community health workers, non-oncology physicians, or even non-physician cadres like clinical officers and things like that can play a major role in this in regards to helping with the lifestyle counseling and even basic psychological support. This is important where oncologist and surgeon and radiation oncologist time is really stretched thin. And then finally, survivorship care blends naturally with palliative care. So integrating the two can allow for seamless symptom management and utilizing established infrastructure. So the idea is not to create two separate things like oncology and survivorship. It's to embed survivorship principles into routine oncology care so every patient can receive consistent whole person support. So I just wanted to share with you a practical tool that you could start using today if you wanted. This is the NCCN Distress Thermometer and Problem List. It's a free, widely validated resource designed to help providers quickly identify survivorship concerns. And what's great about this tool is it takes less than 2 minutes to complete. So it's something that a patient can do when they're waiting to see you in the waiting room. And it opens the door to conversations patients would probably not otherwise bring up. And importantly, it's incredibly accessible. It's available in 71 languages on the NCCN website. So it's really usable in a lot of settings. I checked, I saw Swahili there. I'm pretty sure Amharic was there. It's a simple way to embed supportive cancer survivorship care into routine visits. All right, so wrapping it up, I just wanted to highlight a few takeaways. So first and foremost, survivorship, I hope I've given you a different perspective in how you think about cancer survivorship, and that it's an essential part of comprehensive breast cancer care. It's not something that starts after treatment. It's really meant to be woven through the entire cancer journey. It's all of our responsibility. It's not one particular group like medical oncology. It's medical oncology, radiation oncology, and surgery. And second, high impact, low cost interventions really work across all resource settings. So really simple things like just counseling about physical activity, educating patients to tell you if they're having new symptoms, talking about something as basic as using vaginal lubricants and moisturizers, basic pain management, distress screening. All these things can make a meaningful difference for patients. And finally, prioritize early symptom management, counseling, and continuity. These are the foundations of good survivorship care, and this is really what keeps our patients on treatment and which increases the likelihood of their outcome, of a good outcome. And all these resources on the slide are open access and available globally. And I'm also providing 2 practical clinical resources for those who want to dive deeper into management. And both of these resources are really practice-focused guidance and complement what I covered today. So now I'll turn it over to Dr. Linda Koehler, who will walk us through physical therapy in breast cancer, another critical part of survivorship care. Thank you.
Thank you, Tara. Outstanding presentation.
Thank you.
Can you see my screen okay?
Yes.
Yes.
Okay, let me get situated here. So thank you. So I'm going to pick up where Tara left off, and I'm going to be discussing an important aspect of cancer survivorship, which is physical therapy and rehabilitation. So these are the 3 objectives I'll be covering today. So I'll be describing the role of physical therapy in breast cancer care, identify some of the more common impairments that PT addresses, and then discuss some practical strategies for integrating rehab into breast cancer care. So while the primary focus in breast cancer care is about saving lives, it's important to understand the profound impact some of the breast cancer and breast cancer treatment has on the patient's physical function and quality of life. Breast cancer and its treatment often cause short and long-term physical impairments such as functional loss, immobility, and nearly all patients experience one or more of these physical impairments. And I'm going over some of the common issues in the upcoming slides, but I just want to stress the impact these impairments have on quality of life, because these physical issues make everyday activities more challenging. So if they're not treated, these impairments can lead to decline in function, emotional distress, and long-term disability and adverse effects that can last 10, 20 years or more. So I'm going to be talking about next the role of physical therapy and some of the common impairments that we see. So physical therapy plays an essential role in managing the physical impairments, symptoms, and improving mobility and function after breast cancer treatment. We are trying to get the person to move like they were prior to having the diagnosis, getting back to their normal functional activities. So some of the most common impairments that we see include breast cancer-related lymphedema, movement and tissue restrictions, pain, weakness, both localized and generalized, and sensory changes. And luckily, physical therapy interventions can help support and recovery from cancer and its treatment and reduce the long-term disability from some of these impairments. So I'm going to go over these in more detail in the upcoming slides. So as I go through the next few slides, I'll be taking the resource-stratified tiered approach that Tara just outlined earlier, which is basic, core, and enhanced. So I'm going to begin with breast cancer-related lymphedema. Breast cancer-related lymphedema is a chronic swelling that can occur anywhere in the trunk or on in the arm on the side where surgery was performed. It's a common complication that requires proactive management to prevent progression of the disease and reduce the risk of infection. So when resources are limited, the focus is on simple strategies like limb elevation, skin education on good hygiene to reduce the risk of infection. With core interventions include early screening to detect lymphedema at its earliest stage, teaching patients simple manual lymph drainage techniques, and using available compression materials like compression garments, compression bandages. Enhanced care involves referral to physical therapy for specialized treatment. This includes complete decongestive physiotherapy, which combines manual lymph drainage, compression therapy, therapeutic exercise, and ongoing skincare education. And the goal for this is to reduce swelling, which reduces the risk of infection and progression of the disease. Patient outcomes are best when lymphedema is treated in the earliest stage, but that's not always the case, unfortunately. So the picture here shows a patient with stage 3 lymphedema, also known as elephantiasis. She has stage 3 lymphedema in the left arm and trunk. This is a patient I was seeing for palliative treatment, and you can see the skin changes in the arm and in the trunk area, making it apparent the cancer has metastasized. You can't really tell by this picture, but the patient also has a flaccid left arm because the cancer is pressing on the nerves, so she no longer has function in her left arm, and you can imagine the impact this has had on her quality of life and function. So oftentimes in advanced stages of cancer, there's often pain involved, which is what I'll talk about next. So pain after breast cancer treatment can be related to a number of things. It can be related to the tumor compressing on tissue, or because of treatment such as surgery, radiation, or chemotherapy, or from hormone therapy, the joint pain from hormone therapy. So these interventions often cause tissue injury involving the skin, muscle, and nerves, which can lead to persistent discomfort. So it's really important to understand what the cause of the pain is so you can address the pain with an appropriate treatment. With so many different causes of pain, it's difficult to provide a generalized treatment options just in one slide. So I'm just going to give some basic overviews of how to go about treating some pain related to breast cancer and its treatment. So in general, the basic strategies include just encouraging gentle movement and using positioning techniques to relieve the pain. Any type of pain-free motion can be beneficial. Over-the-counter medications can also help reduce inflammation and pain. Core interventions include structured exercise programs tailored to the patient's needs. Teaching self-manual techniques that target the underlying problems such as scar tissue mobility or nerve gliding can be helpful. Enhanced care requires referral to a physical therapist for specialized treatment. This may include therapeutic exercise, advanced manual therapy techniques, modalities such as heat, cold, e-stim to manage the pain effectively. And the goal is to prevent pain from becoming chronic and helping the patient restore function and improve quality of life. And there are many, like I said, there are many causes of breast cancer-related pain. One of them being restrictions in musculoskeletal issues, which is I'll go through next. Patients often experience tightness in the extremities and upper quadrant along with scar tissue and adherence that limit mobility and cause discomfort. Some basic strategies, including just encouraging exercise and physical activity, is key. The goal is to keep the body moving and preventing stiffness. So core interventions involve structured stretching exercises that are targeted to the affected area that's impacted, teaching patients self-manual techniques such as, again, scar massage to improve tissue mobility and reduce adhesions. These can also be helpful. Enhanced care requires referral to a physical therapist for a personalized exercise program. This includes more advanced manual therapy techniques to address restrictions in the targeted areas and then restore the functional activity. The picture here shows a patient actively performing bilateral shoulder abduction, and you can visually see that the patient lacks shoulder abduction on their left side when compared to the right side due to tissue restrictions. So just an easy way to screen if they're having restrictions. So next, I'm going to give a brief overview of a condition that specifically limits shoulder abduction. So if you're not familiar with what axillary web syndrome is, it's also known as cording, is a frequent but often overlooked complication following breast cancer surgery with lymph nodes removed. AWS involves the formation of one or more tight banded tissue cords that develop in the axilla region, and these sometimes extend down the medial part of the arm. You'll sometimes see them in the antecubital fossa, and they can extend as far down to the base of the thumb, and sometimes you'll see them on the lateral chest wall also. The symptoms usually appear within a few weeks post-surgery, but they can develop months or even years later. The incident rates vary widely, being much higher after full axillary lymph node dissection than after sentinel node biopsy. These cords are thought to be lymphatic in etiology, formed by damage in obstructed lymphatic vessels. But what we do know is AWS or axillary web syndrome leads to reduced shoulder abduction, pain and discomfort, and also has been identified as a risk factor for lymphedema. So physical therapy treatments include gentle myofascial manipulation, stretching exercise, and education on home stretching programs. So in addition to movement and tissue restrictions, patients can also experience weakness, both generalized weakness, which affects overall endurance, and localized weakness, which is specific to specific muscle groups. So addressing these issues is critical for restoring function and preventing long-term disability. So for generalized weakness, basic strategies include encouraging movement through simple walking program and promoting regular physical activity. Core interventions involve a structured physical activity program, aiming for the recommended 150 minutes per week of moderate exercise. And then enhanced care includes referral to a physical therapist for therapeutic exercise. And then in some cases, patients may benefit from gym membership or working with an exercise physiologist or athletic trainer for supervised sessions. For localized weakness, basic strategies focus on generalized strengthening, using household items as weights, making it practical and accessible. Core interventions include structured progressive strengthening exercises, including TheraBands or light weights to target specific areas and specific muscle groups. Enhanced care involves referral to a physical therapist for individualized strengthening program, again, addressing specific muscle groups, often incorporating resistive equipment for more advanced rehab. And if there are no physical deficits, referral to, no movement restrictions, referral to an exercise physiologist or athletic trainer would also be appropriate. So the goal is to rebuild strength and gradually improve overall function. So next I'm going to talk about is sensory loss. So chemotherapy-induced peripheral neuropathy is a common side effect of breast cancer treatment. It often leads to sensory changes such as numbness, tingling, or paresthesia, and can significantly affect coordination, balance, and gait, increasing the risk for falls. So basic strategies include just encouraging safe movement and teaching generalized balanced exercises. Foot care education is also critical to prevent injuries since patients may not feel cuts or pressure points. Core interventions involve structured proprioception and balance training to improve stability, and issuing assisted devices like canes or walkers may be needed for patient safety. Enhanced care requires referral to a physical therapist for specialized interventions. This includes balance and gait training, sensory re-education techniques, and therapeutic exercises to improve coordination and reduce risk of fall. So next, we'll go over evidence-based guidelines. So international guidelines emphasize the importance of integrating rehabilitation into cancer care, not just as an afterthought, but as a core component from the very beginning. So as applied in today's presentation, a key principle is taking a resource-stratified approach, which means tailoring rehabilitation strategies to the resources available in different settings. In addition, a prospective surveillance model is strongly encouraged. This model involves monitoring patients for physical impairments throughout the care continuum, from prognosis all the way through survivorship and into palliative care. Rehabilitations that start as soon as possible, ideally at the diagnosis, rather than waiting for impairments to become more severe. So this proactive approach helps prevent complications and supports better long-term outcomes. So next, I'm going to briefly go over some assessments that can be used to help identify some physical impairments. So when assessing for physical impairments, you can use a combination of objective and subjective measures. For lymphedema, just visual inspection and palpation to check for tissue changes can be very useful. Circumferential measurements can also be converted to volume for more precise tracking, so taking circumferential measurements on the extremity. Patient-reported tools like the Lymphedema Life Impact Scale are also useful tools to understand how swelling affects daily life. For movement restrictions, using goniometric measurements for active and passive range of motion. You can also check for axillary web syndrome and scar adherence. And the disabilities of the arm, shoulder, and hand questionnaire helps capture functional limitations from a patient's perspective. Weakness can be evaluated in a couple ways. For localized weakness, you can use manual muscle testing and grip dynamometry. For generalized weakness, you can rely on functional tests like the 6-minute walk and test and walking speed. Pain is measured using simple validated scales such as the numeric pain rating scale from 0 to 10 and the visual analog scale. Sensation is assessed for neuropathy with light touch. For balance, functional tests like the timed up and go and 5-minute sit to stand test can help identify fall risk in patients. So these assessments allow us to monitor changes over time and guide individualized rehabilitation plans. I know this is a busy slide, but I want to talk to you about a project that I've been involved in more recently. I've been working with a multidisciplinary team from the US and Canada who recently developed a core outcome set for breast cancer-related lymphedema. And if you're not familiar with what a core outcome set is, it is an agreed standardized set of outcomes that should be used in clinical and research settings related to specific areas of health. Currently, we are using different outcome measures across studies, across disciplines, across clinics, across countries on a variety of health issues. And this variability limits our ability to compare results, synthesize evidence, inform best practices, and support global patient care. The core outcome set for breast cancer-related lymphedema that we developed displayed here, and I believe Stephanie will be sharing it with you also. It balances what is realistic in time-constrained environments with additional measures that can be used when resources allow. And these outcomes also align with the surveillance model showing from pre-surgical into survival. So we'd like to expand this work by developing an international core outcome set for all cancer-related lymphodemas with the goal of unifying global efforts. So I'm going to shamelessly put a plug in to hopefully recruit some of you. So if you're seeking partners, if you're interested in this, and collaborating on developing an international core outcome set for cancer-related lymphedema, please contact David Doublestein, and there's a QR code here also. So to sum this up, I'd like to leave you with a few practical strategies to improve rehabilitation access. First is task shifting. Tara actually mentioned this in her presentation also. By training nurses or community health workers in basic physical therapy techniques, you can expand the reach of care without relying solely on specialized therapists. And this is particularly important in rural and underserved areas. Telerehabilitation is next. This offers a powerful solution with the use of mobile platforms. Patients can receive exercise instructions and treatment guidance remotely. This reduces travel barriers and ensures continuous care with the patient. Community-based programs are another effective strategy. Group sessions in local clinics not only make therapy more accessible, but also provide social support, which can improve adherence and outcomes. Low-cost interventions are also needed, so simple tools like elastic bands for exercises and locally made compression sleeves can make rehabilitation affordable and sustainable. And finally, partnerships are essential. Collaborating with organizations and global health initiatives like the one we're participating in today helps us secure resources, training, and funding to scale these programs effectively. So these are just a few strategies to implement rehabilitation into breast cancer care. And those are the resources and questions. I'm going to stop sharing because I believe we're opening this up to both.
Well, thank you, Dr. Koehler. Outstanding presentation, very useful. I'll see if there's any questions from our participants first. You can either go through the chat, raise your hand, or maybe even just speak out loud. I think Dr. Mazunga had his hand up. I don't know if he's still on or if he had a question or clarification. Well, I may ask the participants a few questions, and see what services you have. Do you and your institutions around the world have a survivorship program for cancer patients in general or for breast cancer patients specifically? And feel free to comment on the chat or raise your hand or talk, whatever you want to do. And I guess I'll ask the second question. Do you have a cancer-based physical therapy program at your institution? Someone's asking how to speak. Can they speak? Stephanie, do you know?
I think so, but let me.
Hello.
The
Hi.
person that just chatted, I
Hi.
definitely invited him now.
Hello. Could you speak me?
Hello. We can hear you.
Could you hear me? I can speak you.
Yes.
Hello. Hi. I'm Abdullah from Pakistan, and good night. And a very nice information I can get from Derek and Dr. Linda. It's very informative and it's very elaborative. And one thing I asked to Dr. Todd from your questions, because we were like in developing countries and its survivorships only depend upon the, you can say the coming the patient in the OPD for follow-up. Most of the patients are, we do complete, we do give the complete education about their disease, and we do that knowledge of them that you have to continue the follow-up, but there are certain restraints, some people do follow our instructions, but the survivorship is going to be hindered at that point when people are not going to be coming clinics for follow-up. That's going to be somehow a difficult problem for us. And the typical that you talk about the edema patient that we in my fellowship program, I hardly see 2 or 3 patients in the lymphedema status. That's very pathetic condition for that patient, and in that way we are going to follow them. We take their house number, their phone numbers, and then we're going to call them, and we we are going to arrange by ourselves for transportation, and then we are going to follow them and do the survivorship for that patient.
Yeah,
Thank
can
you.
I say a few things to that?
Yes.
Thank you for sharing. I think that that's a common issue worldwide is follow-up. You know, once you're done treating a patient, they go back to their community and they don't come back for follow-up. So one potential solution, which it sounds like you're already providing some education, but it would be education potentially that they can take back to their community providers locally, which again I know is a challenge as well, because not every patient has access to a primary care provider or like a general practitioner that they see for preventative care. I know that that's not a thing that is structured across the world. But if the patient has some sort of education at sort of discharge from oncology that they can use to empower themselves and that they could share with any potential healthcare providers, because it might become pertinent at some point if they're having a new symptom for their local healthcare providers to know that they are a breast cancer survivor and that they really need to work these symptoms up, or that they've had anthracycline exposure and they are at risk for a heart failure. So I think just figuring out a way that works within your system to provide the patient with this information that then they can take back to their local community would be a great start to calling that cancer survivorship in your program.
Hello.
Yes, we can hear you.
Yes. Dr. Tararik, I completely understand your as you are going to gives a certain opinion, and we do educate patient, and the patient respond. But there are certain, in Pakistan system, they are very far away people, and people have to travel for millions of miles, and usually, can the 1,500 kilometers away. They live in a very low socio-economic level, and they are low educationally. They are not up to the mark. We do our best to educate them. We would do our best to enhance their possibility to get recovery and follow up in the hospitals. But we are having we are not going to achieve that survivorship that would be possible in your setups. The people are more educated, they have good facilities, and unfortunately we are going our best to do this plan by ourselves, but there is always a question mark there.
Yeah, I hear you. There are always so many barriers to so many aspects of cancer care. And I think the point of the presentation was just to, it sounds like you're already educating your patients on these topics and you're doing the best that you can with what you have, with what your patients have to work with. So it's just also thinking of that this is part of what you're already doing is part of cancer survivorship. So you're already providing cancer survivorship care within your oncology practice. And that's something to be commended. And then as you again, just sort of working with what you have and the resources that you have and the resources that your patients have, but giving them this education, whether or not they are able to use it, is what's important.
Yes, I understand it, and I agree with you.
And I just want to, one of the things you mentioned was lymphedema, and the patients are going back, far away and probably are not going to have access to the interventions, the more advanced interventions. The key, again, would just be education. And I would just focus on, and you're probably already doing this, but just the hygiene, because if they're at high risk of lymphedema, they're at high risk of infection. And just teaching hygiene, really, really good hygiene to reduce the risk of an infection is the basic, one of the basic educational things you can provide when they're there, with the understanding that, they might not have access to anything else, but maybe just trying to keep, the area as clean as possible.
Thank you. And looking through the
Yes,
chat,
Dr. Linda. Yes, sorry, Dr. Todd. Dr. Linda, I will now, next time, I will follow your instruction, and I will surely let them know how to maintain their hygiene, and most probably they are going to be more, you can say, get healthier approach by maintaining the hygiene, and I will consider it in the next time.
Thank you. And looking at the chat, doesn't seem like there are many survivorship programs or physical therapy programs that our participants have access to. We have a question, Dr. Linda, from Dr. Marcel from Rwanda about surgical intervention of patients who have lymphedema after a surgical procedure.
So that I don't know specifically what type of surgical intervention you're speaking or would like to talk about. So there are surgical interventions for lymphedema. There's not a lot of support. Well, it depends on the type of surgical intervention. There's some microsurgeries that are starting to be involved, but that's a very niche group that is doing those type of surgeries. It really depends on the situation. So people who have maybe stage 3 elephantiasis and have a lot of functional limitations, maybe doing a debulking procedure might be appropriate for that person, but they would need follow-up care. So I don't know if that helps answer your question, Marcel. I don't know what type of resources are available for. If you can expand a little bit more, I might be able to answer that question a little better.
And a related question, Dr. Linda, Dr. Tesso from Ethiopia had a question about do we need to do surgery for AWS?
Yeah, that's something some people have gone in and done, but it's really not necessary to go invasive, to do an invasive surgery for something that could be addressed with just, manual techniques and some gentle stretching. It seems unnecessary because now you're putting the person at high risk for something that can be addressed with just therapy and just movement. So in general, the cording will improve over time anyways. So surgery wouldn't be necessary.
Thank you. Well, it certainly seems like a very big unmet need in many developing countries right now. I know in the United States we take these services for granted, but particularly with the advanced stage of presentation that you're seeing in Ethiopia and Pakistan and other parts of the world, these are pretty critical services. And it seems like you could, if you have time, of course, time is a big cost. If you have time, you would be able to provide some pretty useful education for patients, but everybody's stretched for time, I think.
Yes. Dr. Todd, what thing I want to mention here? See, can you hear me, please?
Yes.
Okay. See, the one thing which I unfortunately seems that yes, the population of doctors and surgeons, yes, they understand this thing, and somehow the people who are mediocrely educated and they are educated, and some are Google people, they take the education from Google and then they're going to apply it or to the doctor and to the society, and this is something different. There are certain population which are below average,
Yeah.
they don't have proper education, and my country which I face myself is purely the problem is of education, who are not able to get education, who did not able to have the severity and the extremity of the condition, and how can I get the approach to educate them that this is a kind of cancer and you have to treat them like this way. And there there's certain superstitious things in society, and for these peoples it's and in certain situations there are many things are going when you are going to treat a patient, there are many perspectives are going to include. There's a certain ayurvedic thing, there's certain ayurvedic thing, there's an homeopathic remedy, there's no there's superstitious things are going to be involved in one treatment. For this purpose, this is going to be difficult for us. There are certain educated people who know the disease and who are going to progress the disease. How and they know the knowledge. They have the knowledge. How get education of this knowledge? How get treatment? What is the chemotherapy? What is the radiotherapy? What is the hormonal therapy? What is the surgical management? And how we are going to do the survivorship of this? For that patient, for these population, we are good to manage them. But those population who are Google population, and those population who don't have even a single word of that knowledge of that disease, for that population, it's very difficult for us in here in Pakistan. Because I think that to get knowledge from Google, and from the Google, they are going to get the half-baked knowledge, and they are going to apply it. And there's certain other psychological problem in our society that every disease is not the same disease. And if I have a stage 2 disease and at this stage 4 disease, the stage 2 people is going to advise stage 4 that do this way. But unfortunately, the plethora is different for all for both of these patients, and management plan is different. That's why we are going to be having problem in our society.
Nadersha, we have the same problem here in the United States, especially with Chat GPT now. Dr. Linda, Dr. Marcel clarified his question about how do you decide when to perform lymphovenous anastomoses for lymphedema after surgery?
Okay, yep, that
Does
helps.
it work? How do you decide when to do it?
Yes. Well, first it hopefully someone has the ability to do that type of surgery, because that takes a trained surgeon to be doing that. But what my experience is that the patient has to be very adherent to the complete decongestive therapy first, because even with lymphovenous anastomosis type surgery or some of the other surgeries, they have to be compliant with following up with still doing complete decongestive therapy or supportive care. So they still will require to wear compression garments. So they really need to show adherence. So depending on if they've been extremely compliant with complete decongestive therapy first, and they're not showing the outcomes they would want to see, then that person might be eligible. So someone who has failed supportive management or failed CDT might be somebody who wasn't adherent, and that would not be a good candidate for surgery, because then they're not going to be following through with what is needed to maintain that those outcomes. So I hope that answers your question. From my experience, it really.
Yeah, there's another comment or question about from Dr. Jagbe. The anastomosis for lymphedema is cumbersome. Does it really give a better outcome? I don't know that answer.
Oh, I'm sorry. I didn't. What was the question? I'm sorry.
Oh, I'm sorry. Does the anastomosis for lymphedema is cumbersome? Does it really give a better outcome?
It might in the short term. From what I have read in the surgeries, it might be short term improvement, but then long term it tends to fail and might not have long term improvement. So again, the the evidence out there with some of the surgeries. There are a lot of different types of surgeries. And it really depends on the skill of the surgeon and what outcomes you're looking at also. So I hope that answers the question.
Okay, the approach that I have tried to pursue here in the United States is the best way to treat lymphedema is to prevent it and to try to minimize the number of patients who have an axillary lymph node dissection. And we have really been utilizing neoadjuvant therapy for that to try to downstage the axilla for those patients with clinically palpable lymph nodes, and then do a much more targeted lymph node excision. I
And
think
early diagnosis is also really, really important. We know that if we can catch it in the subclinical phase, meaning that there's just starting to be some small amount of swelling, and we address it with compression at those early stages, we can prevent it from progressing. So same as what Todd was saying in the States here, we really early diagnosis is key.
there's one last question, and then I'm going to call it. Dr. Gemetchu asked, "What is the role for traditional healers in kind of I think in breast cancer care, supportive care overall, and can they be trained through some sort of short-term training mechanism?"
Yeah, I would think so. The approach that we were talking about is task shifting, that there's somebody in the community that could help with providing some of the PT techniques, I think would be very appropriate. If they would have it wouldn't take that much training to be showing them some hands-on techniques for to help stretch the cording. That would be, I think, very appropriate and in that role. Great idea.
That is a very good idea. Well, I want to really thank our speakers today for very high-level presentations, and really thank you guys for starting a conversation. And I think this back and forth is probably the best way that we could all learn from each other. So thank you very much to Dr. Tara, Dr. Linda. We are not having a seminar in January. We're going to skip that, but our next seminar will be February 3rd, 2026. So the new year, and we'll give you more details on that. Have a good morning, afternoon, and evening, everyone. Thank you.